Epidemiology. Its prevalence is known by more than 7 cases have been described. Malakoplakia can occur in all ages with a mean age alienus of 15 years and predominantly female.
Malakoplakia is a rare condition characterized by yellow or white, soft raised patches 3 to 4 centimeters across. Clinically, malakoplakia may be mistaken for carcinoma, and the condition occurs much more frequently in women than men, and the usual age at which it occurs is around the 5th decade. This is a particularly florid example of malakoplakia with numerous yellowy white plaques. Malakoplakia is a granulomatous inflammatory condition, and it is usually associated with E. coli or Proteus vulgaris infection. It is most frequently seen in the bladder and typically presents with symptoms of urinary tract infection and hematuria. The condition may also occur in other areas such as kidney, colon, testes, epididymis, bones, and the lungs. Malakoplakia is a complication of recurrent infections, and it is more frequently seen in immunosuppressed patients, particularly renal transplant patients. It is thought to be caused by a defect of macrophage phagolysosomal response to bacterial infection, usually by gram-negative coliform bacilli. This is an example of malakoplakia involving a transplanted kidney. Microscopically, malakoplakia is characterized by sheets of histiocytes with abundant granular pink staining cytoplasm, and these are called von Hansmann histiocytes. In some of these histiocytes are intracytoplasmic calcified laminated inclusions, and these are known as Michaelis-Guttman bodies. And the Michaelis-Guttman bodies are the calcified remnants of the gram-negative bacilli. This is the histological appearance of malakoplakia. It is composed of sheets of histiocytes with abundant pink staining granular cytoplasm, and within some of these cells are structures that resemble bullseyes, and these are Michaelis-Guttman bodies. Michaelis-Guttman bodies are the diagnostic feature of malakoplakia, and a really good way of demonstrating these is with a von Cosse stain that stains them dark brown.
Etiology. Malakoplakia seems to be due to a defect responsive to a bacterial infection. Macrophages and monocytes show detective phagolysosomal activity. They phagocytose bacteria but are unable to digest then complete.
Here we have the part of the kidney parenchyma with something that looks like a tumor mass. Here we have the renal cortex. This is the capsule of the kidney, and here we have the perirenal adipose tissue. On the higher magnification, we can see that this mass is composed of sheets of characteristic cells, and all of these cells are actually macrophages. They have slightly eosinophilic, foamy cytoplasm and small, round, inconspicuous nuclei. These larger round structures here, those are not nuclei of the cells, those are intracytoplasmic inclusions. They are usually larger than the nuclei of the macrophages. They are basophilic, and some of them have central dot. These intracytoplasmic inclusions are called Michaelis-Guttman bodies. and they are characteristic for so-called malakoplakia. So this is not a tumor, this is inflammatory lesion. It is typically caused by E. coli infection. The macrophages then phagocytose bacteria. However, the intracytoplasmic destruction of the bacteria inside of these macrophages is defective, and part of these digested bacterial products function as a nidus for calcium deposits. So all of these structures here, those are small calcification inside of the cytoplasm of the macrophages. The accumulation of these macrophages then creates a mass. Sometimes we can see similar accumulation of these xanthomatous macrophages, however, without calcifications and without these Michaelis-Guttman bodies, and that would be called xanthogranulomatous pyelonephritis. Michaelis-Guttman bodies would be positive for calcium-specific stains like von Cossa stain, for example. Immunosuppression is a predisposing factor for malakoplakia. It could be associated with defective lysosomal degradation of these bacterial products inside of the macrophages. Here we have part of the normal renal parenchyma with the glomeruli and renal tubules. Thanks for watching.
Main and treatment. The treatment consisting of antibiotics with intracellular molecules, fluoroquinolones, trimethoprim, sulfametazole. Currently, the duration of therapy is not yet standardized. Is pseudohumoral cast. Surgical removal of the lesion is required. Depending on the organs involved, the different diagnoses included malignant primary of metastasis, malignant disease, inflammatory disease, sarcoidosis, Crohn's disease, infection disease, tuberculosis, Whipple disease, and skin fungal infection.
This is the lesion from a female of 72, and the answer is, of course, an inverted papilloma. There is no evidence of nuclear atypia, and the nests of urothelial cells are lined by umbrella cells. The CD44 shows characteristic full-thickness staining indicative of a reactive type of urothelium. So very briefly, inverted papillomas are benign. They typically occur on the trigone or bladder neck, and they are commoner in men. This case was a type of transitional cell carcinoma, but this is a micropapillary variant. You can see why micropapillary is so called, because the papillae have micropapillae. Micropapillary carcinomas are important to diagnose because they are an aggressive variant of urothelial carcinoma, often deeply invasive. They are more frequent in males, and they have a similar cytokeratin pattern to typical urothelial carcinomas. Interestingly, there may be CA125 positivity, suggesting that the tumour cells may be glandular. A bit more information would have been useful here, but this is an example of schistosomiasis. So among the inflammatory cells you can see schistosome eggs, and at the bottom of the egg here is a terminal spine. And it is the terminal spine that is classical of schistosoma hematobium that causes schistosomiasis in the urinary tract. It is the eggs that cause the problems with schistosomiasis. They cause inflammation, granuloma formation, and fibrosis. This is a good example of macroplastique, presenting as a bladder lesion. It has a characteristic histological appearance with these clear fragments surrounded by foreign body giant cells and lying in a rather fibrous stroma that they have caused. Macroplastique is used to treat vesicoureteric reflux and stress incontinence, as in this case it may present years later as a bladder lesion, and once you've seen it you'll always remember what it looks like. The final case was an example of malakoplakia. This is diagnosed by the presence of von Hansmann histiocytes, and these are the pink cells with abundant cytoplasm, and the Michaelis-Guttman bodies that look like bullseyes. Malakoplakia occurs more frequently in women. It is caused by recurrent urinary infections, and as said before, the characteristic features are Michaelis-Guttman bodies and the von Hansmann histiocytes.
Clinical description. In most cases, 50 at 80%, malakoplakia affects the urinary tract, bladder, kidneys, and urethra, and there has been cases of locoregional extension, retroperitoneal region, and lymph nodes. Other organisms may also be involved into the health system. Left colon, sigmoid, rectum, stomach, behind the second most common area. 15% of their areas are in genital tract, skin, neck, tongue, lungs, and central nervous system. Patients may be asymptomatic or have non-specific clinical symptoms. Fever pain that vary depending on the organ involved. In case of an affection of the urinary tract, the patient usually presents chronic infection of the urinary tract and symptoms like urinary urgency, by vacillation, intermittent dysuria, hematuria, and proteinuria.
If you remember from the previous case of papillary carcinoma of the ureter, the papillary structures looked very well formed, and therefore it was probably a lower grade tumor. Well, here is another papillary tumor, but it is of the bladder now, the same type of epithelium as the ureter or the pelvis or the calyces. And in this case, the papillarity or the papillosity or the papillariness of the tumor is not appreciated that much, is it? Oh, I think you could see that there is some general connective tissue, and you could see that they're surrounded by these darker, bluer tumor cells. But in this case, you don't see nice, well-formed papilla, and therefore you would not expect it to be as low grade as the previous one that we saw. And not only is this not lower grade, but it's also doing something that the other one didn't do either, and it is truly invading the smooth muscle of the bladder wall. Here is an area of necrosis. Here's an area where these tumor cells are invading the smooth muscle, and in addition, the transitional tumor cells do not look as nice as they did than in the one where we had nice formed papilla. In addition, you can see that's an abnormal mitosis. There's a Mercedes-Benz. There's a mitosis that wants to go in probably 3 different directions. There's another probable abnormal mitosis. And look how these tumor cells infiltrate these smooth muscle fibers. I want to show you one more thing about this case. So you know that this is a higher grade, perhaps if you want to call it 3 or 4 transitional cell carcinoma. Papillae are not discerned easily. The tumor cells diffusely invade all of these pinker muscle fibers here. And in addition, when you look at this, you might say, hey, is that a little piece of tumor out there beyond the bladder wall and the fat as well? Well, let's blow it up and see if it is. No, it's not. It's just a normal little lymph node, isn't it? It could have been tumor, or it could have been tumor inside the lymph node, but in this case, this is just a little lymph node. Let's look at the other one as well that was next to it. And once again, I think I can convince you this is all lymphoid tissue. So even though this tumor may have metastasized to the lymph nodes, we don't see anything in this field in particular that shows extent of the tumor beyond the muscular wall of the bladder or into the surrounding perivesical fat. We do see that the tumor, however, goes very deeply into the wall and has disrupted all of these smooth muscle fibers here and here and here. But this is a deeply invasive, high-grade or poorly differentiated, barely papillary transitional cell carcinoma of the part of the urothelium that is in the bladder. Thank you very much.
Diagnostic methods. Diagnostic methods. In diagnosis, it's difficult due to the absence of clinically specific symptoms. Chartic image it is based on endoscopic that reveals the presence of the words of vascular wind or polypoid nodules or plaques, and is confirmation by biopsy of the affected tissue.